Good morning, everyone. Welcome to day 2 of Place Matters. I am so excited to have all of you here and be having these wonderful conversations about the work that we all do and care about deeply. I'm Karen Gerard. I'm the section manager for the Health Promotion and Chronic Disease Prevention section in the Oregon Health Authority, and it's my pleasure to welcome you here today. Yesterday, I was just so inspired by all of the sessions that I attended and our plenary speakers. And what I'm excited about following that up with today, because when we talk about these risk factors like tobacco use, excessive alcohol use, physical inactivity, and poor nutrition, I think we can forget to connect the dots for people that the result of those risk factors is real sickness, misery, an inability to have a job, to care for our loved ones, to do the things that we love so much, because they manifest themselves in very serious chronic diseases like diabetes, heart disease, stroke, cancer, asthma, arthritis, you name it. These risk factors are basically major causes and contributors to the development of these diseases and also hinder our ability to manage them. And that's why it's so important to connect public health and health systems in the work that we do, because we are all part of a system that helps to make our communities healthier. It's my pleasure today to introduce Zeke Smith. Zeke is here today to speak about healthcare and public health, working together to keep Oregonians healthy at home, work, and school. Zeke, since 2012, Zeke Smith has served as the Chief Impact Officer of the United Way of the Columbia Willamette, leading their efforts to break the cycle of childhood poverty across the Portland metro region. United Way does this by bringing diverse community partners together through increased funding, volunteers, and shared expertise in order to better the lives of children and families and to improve the systems designed to support them. Previously, Zeke served as the Chief of Staff at Portland Public Schools from 2007 to 2012, where he was responsible for managing the executive leadership team, strategic planning for the district, and led district external affairs, including communications, government, and community relations. In Zeke's prior work experience, he worked on a variety of positions and community-based nonprofits to improve the lives of kids, particularly those of color and living in poverty. Zeke has extensive professional experience as a facilitator and strategic consultant with numerous local, state, and national organizations, with a particular focus on communities of color. Zeke is currently the chair of the Oregon Health Policy Board. Zeke is proud of his Dutch, Indonesian, Osage, and Oneida heritage and lives in Northeast Portland. He is married and has 2 daughters who attend Grant High School. He is also a class of 28 American Leadership Forum Senior Fellow and a German Marshall Memorial American Fellow. Please join me in welcoming Zeke Smith.
Hello, everybody. I am glad to be here. Let's try that again. Hello, everybody. That was really nice. So I just want to clear up a few things. One thing is I can hear some papers ruffling. I think people are looking through their agenda and they're like, whoa, who's this Zeke Smith guy? I thought Lynn Saxton was going to be speaking to us this morning, Director of the Oregon Health Authority. I'm here to tell you, if you're in the front, you are correct. I don't look anything like Lynn Saxton. And if you're in the back, I may still look to you like Lynn Saxton. That's more a function of how far away from the stage you are than it is what I actually look like. But just so you know, I don't have my glasses on now either, so I also can't really see what you look like in the back. So we'll be okay on that front. So Lynn couldn't be here today. She was called away by the governor, and when you're called away by the governor, you go. And in her stead, you have me. Which is great. I'm excited to be here. I'm really excited about the work that you all are doing. I do want to acknowledge I am not a health expert. I don't work in public health. I don't work in a health department. I do sit on the Oregon Health Policy Board, so I have this really interesting position as both a consumer and as a citizen in Oregon to be able to actually have a direct relationship to how we make the health transformation in this state work and where public health fits in the middle of that. So I'm not going to try to tell you from an expert perspective, kind of give you perspective from an expert perspective. What I will do is I'll give you my perspective on kind of where we are, and I'll share a little bit about what I know about what the Oregon Health Authority is doing. And I hope that that will inform what you're doing here. If you were looking for experts, you've got a whole bunch of them that you're going to hear from later, which is exciting. So we'll do that. So let's see. So the vision of the Public Health Division of the Oregon Health Authority is to ensure the lifelong health of all people in Oregon. Where we live, work, play, and learn matters to our physical, mental, and emotional health. Much can and must be done to create and maintain healthy communities in Oregon, from our large urban areas like Portland and Salem, to our university towns like Eugene, Corvallis, and Ashland, to our rural and frontier communities like Joseph, Siletz, Oakland, or Burns. I want to share a short video with you quickly that the Health Division, the Public Health Division created that captures the challenges we face and some of the opportunities that are in front of us. So, yeah, you can clap. Primarily, I think you should clap because for the rest of you that are presenters, I can attest to the fact that we have a great AV team that went off solidly. It's always that moment when you're like, okay, what's going to happen with the video? But we had no problems, so thank you guys. So when considering what I wanted to say today, I was struck by the immediacy and relevancy of the title of this conference. We find ourselves talking a lot these days about what matters, and for that matter, whose life matters. Important and right questions for us to be considering. And in this place, this state that so many of us call home, plays a significant role in both what and who matters. Place continues to define the health of individual Oregonians and entire communities. Aside from race itself, place, where one lives, might be the single greatest determinant of education, employment, environment, livelihood, happiness, and ultimately of health itself. So yes, place matters, and in fact, it matters more for some than it does for others. Given that this conference is about public health and that we know we need to address considerable health inequities within communities across our state, I want to share a few thoughts about each of these ideas and the relationship between the two. Equity should be the foundation of all the work that we do in the health system, not simply an add-on strategy. What would it look like if equity was truly at the foundation, at the core of our health system transformation? So what do we know about health inequities in Oregon today? According to our Public Health Division, through the 2016 Public Health Modernization Assessment, every local health authority in Oregon, except for one, was not satisfied that they have adequate health equity capabilities. According to the recently published Oregon Health Equity Alliance report, A Healthy Oregon, 21st Century Health Equity Investments, which, by the way, I would suggest you all take a look at if you haven't had a chance to read it yet. It's great. We know the following familiar data points. Infant mortality rates are more than twice as high amongst American Indians and Alaska Natives as they are amongst the white community. African Americans, Native Americans, and Pacific Islanders are more likely to experience chronic disease and to die younger than their white peers. People of color and immigrant communities are more likely to be uninsured or underinsured, leading to increased likelihood that they will have worse health outcomes and their health care costs will be higher as they're more likely to use emergency services. Nothing new, but important to identify. Two other things we know about communities of color in Oregon. These same types of inequities are consistent across virtually every social determinant of health: housing, education, employment, and these communities are growing every day in virtually every part of our state. Thankfully, our communities of color are here to stay, and our future as a state will depend on our ability to address the systemic inequities that so acutely impact these communities. One way you can begin to tackle these inequities is by ensuring our workforce is grounded in the cultures, experiences, and perspectives of our communities of color. So what do we know about the degree to which our modern health workforce reflects the diversity of our state? Well, we know it doesn't, but we don't necessarily know by how much. Our most recent report on the diversity of the health workforce in Oregon, presented to the Health Policy Board's Health Workforce Committee in 2014, captures data on the 2012-13 program year. And by the way, they'll be revising that with newer data by the end of the year, which should be interesting to see. So while there are some significant gaps in the data, this report concludes that the proportion of African American, Native American, Hispanic, and Pacific Islander healthcare professionals is lower than the proportion of these communities represented in the overall Oregon population. Again, not surprising or new news, but important nonetheless, in particular, I think this becomes relevant as we consider how we most rapidly change this reality. Whether we're talking about healthcare or education, if we want to change outcomes for communities of color, we need more professionals of color. More professionals who reflect the lived experiences of these communities and speak their languages. This is not something our systems are well designed to do quickly. So what do we do about it? So allow me to pause on that question for a moment and consider what we know from applying a public health perspective to our health system. Our public health colleagues will tell us that the health and wellness of our communities depend on a strong and effective partnership between public health, primary care, and community. Whether it's 10 or 20%, we all generally understand that clinical or medical services make up a small portion of the overall system that contributes to both individual and community health. If we want to achieve the triple aim, better health, better care at a lower cost, we have to engage the community more broadly. In this model, community envelops all of the work being done by public health and clinical services to ensure health equity. Public health prevents communicable and chronic diseases, protects from human health environmental risks, and ensures equitable access to health services through policies and systems that support wellness for everyone. Collaboration between providers, public health workers, and the community can prevent or lessen the incidence and severity of disease and injury, improve the health of our communities, and reduce the demand on our healthcare system, especially among the most vulnerable. So we achieve the triple aim and ensure healthier places across our state through this critical partnership, right? So stepping back to the problem I mentioned a minute ago, how do we rapidly improve the diversity of our healthcare workforce? Maybe this public health solution helps us think of this slightly differently. Not to let the system off the hook for diversifying the workforce, mind you, but rather the health system, including public health, will need to partner more significantly and more intentionally with community-based partners to address health equity with appropriate urgency. The Public Health Advisory Board of the Oregon Health Policy Board identified health equity as a 2017-19 priority in our public health system modernization. Given the dramatically changing demographics of our population, especially our younger population, and the significant underrepresentation of professionals of color across healthcare and across the state, we will need to think differently about partnership. If we really want to address pervasive inequities, we need to begin to see communities at the center of the solution and not just a problem to be solved. One of the things I appreciate about a public health lens to our work is that it does place community at the center of the solution making. You can see in the public health pyramid, which really demonstrates the need and effectiveness of population level interventions. Achieving lasting impact on health outcomes requires a focus not just on patient care, but on community-wide approaches aimed at improving population health. Interventions that address the conditions in the places where we live, learn, work, and play have the greatest potential impact on our collective health and close the gap by health disparities. So by focusing on these social determinants of health and on changing the context to make healthy choices easier, we can improve the health of everyone living in a community. I want to acknowledge that I'm using community and communities somewhat interchangeably. Community and communities. While this is on purpose, I think it's important we recognize the distinction. Too often we say community as an umbrella. Without being explicit, we can mean both geographic community or cultural community. We can mean the whole community or a specific community. As we think about the intersection of public health and health equity, I would challenge us to more often speak about communities, both geographic and culturally, and to use the general term community less often. So indulge me for a moment as I ask a simple question. Why should we care about public health? We know that 80% of what shapes our health happens outside the doctor's office. Public health promotes the health of all people in Oregon by protecting people from communicable diseases, preparing for and responding to emergencies, limiting environmental risks to human health, promoting health and countering the impact of disease and injury, and ensuring equitable access to quality health care. This diversity of ideas is both what makes public health an incredibly important and powerful vehicle for affecting greater health of our communities, and it is an incredibly daunting challenge. In some ways, it's like everything in the kitchen sink. And in our state, we do not currently have the infrastructure, nor have we yet made the full commitment to build a system that adequately addresses each of these issues in a holistic way. A modern public health system is vital to ensuring both basic public protections critical to the health of all Oregonians. So we know that public health is a key component to health system transformation and the triple aim of better health, better care at a lower cost. And thankfully, Oregon has made a strong commitment to transform our system so as to meet the triple aim for all of our community members. However, our current system is not equipped to provide basic public health protections consistently and universally across our state. In our 2016 public health assessment, state and local public health authorities from across the state found that more than a third of Oregon communities, over 1 million people, have only limited or minimal foundational public health programs. By committing to building a modern public health system, we demonstrate our commitment to ensuring a healthy life is within reach for everyone in Oregon. In the meantime, we continue to rely too heavily on local communities to define and build their own systems with limited support from the state. Don't get me wrong, the Public Health Division of the Oregon Health Authority is working hard to both build our commitment to a modern system and a plan for getting there, but we have to look to local communities for public health innovation. One local Oregon community that has innovated its approach to place-based health is Crook County. Crook County Public Health used a one-year Healthy Communities grant to assess how to improve the built environment for biking and walking to prevent and manage chronic disease. The health department conducted a health impact assessment with community participation to understand what evidence-based options would have the most health benefits for their rural community. The results of the assessment were included in the Regional Health Improvement Plan and resulted in community partners funding a new bike path, bike park, and mountain bike trails. Perhaps this is better said from someone in Crook County. I'd like to share with you Bob Orlando's perspective. Thanks, Bob. Bob has no idea that his face was just plastered on a wall in Portland, Oregon. But we appreciate it. We also know that there are great examples of partnership between state programs and local public health authorities. One example of this is the Oregon Tobacco Prevention and Education Program, TPEP. 2016 actually marks the 20th anniversary of this highly effective program. Since TPEP started, cigarette consumption in Oregon has declined by more than 50%. So the place-based approach of TPEP is effective, and we plan to expand this approach to other health issues in a modern public health system. We'll look to both local innovation and joint partnership between the state and local communities for what we can build upon, as we know we cannot build a modern public health system without an effective balance between local and state support and programs. But in order to strike this right balance, we'll need to build out core infrastructure at each of these levels, and we know that we've got a long way to go to get there. The public health modernization assessment I talked about before found that identification and prevention of environmental human health risks are limited or minimal in 2/3 of Oregon's communities. Right now, our public health system is not equipped to handle emerging environmental health issues such as childhood lead poisoning, poor air quality, and the health effects of climate change in rural and frontier communities. Local and state public health have begun working together through the Healthy Places Initiative to understand what public health infrastructure and strategic partnerships are critical to address environmental risks in our communities. We will build from the best practices and evidence of effectiveness from our Healthy Communities programs. We will more effectively respond to emerging environmental risks and build community resilience by leveraging foundational capabilities and proven public health infrastructure. And while we must build with a sense of urgency, we also must build a sustainable system. The modernization assessment identified a $210 million biennial gap between what it will take to build a fully loaded modern system, where we have adequate foundational capabilities across our state and the fragmented system that we currently have. If that money magically fell from the sky tomorrow, we wouldn't be ready to spend it all right away. The gap is too large. So the trick will be in phasing the investment of money, time, and talent in a manner that ensures sustainability and in a manner that ensures much greater health equity. So what are some takeaways from the work we're doing together? We must achieve greater health outcomes for all Oregonians, and specifically must tackle deep inequities for Oregonians of color and in rural Oregon. Modernizing the public health system is in the best interest of all partners who are invested in the health of our communities. We know that there are a few key elements that lead to this success. Number one, work with the right partners. Convening community partners, clinics, CCOs, public health and delivery organizations, and ensuring that team members are empowered to make decisions. Number two, be very clear about expectations. Reviewing goals, outputs, and deliverables, defining the population early, emphasizing cross-organizational systems thinking, and providing lots of support for data collection. And number three, balance careful planning and flexibility, providing in-depth tailored technical assistance and facilitation, conducting ongoing evaluation and planning for course corrections, and expecting that cross-sector collaboration is challenging. So I want to think about each of those concepts for a second with an equity lens, which brings a greater amount of clarity to it for me. Number one, work with the right partners. If we want to truly tackle health inequities which are most pervasive and persistent within communities of color, we've got to reach into the communities for the right partners. Culturally specific organizations, those organizations born up from within their communities, are best suited to be partners in addressing inequities within their own communities. Number two, be very clear about expectations. We must be explicit in our interest to address health inequities, and this means it must show up in all that we do. We cannot talk about a modern and effective public health system without naming health equity as the ultimate goal. We can't build a modern public health system if we don't set clear goals and expectations about addressing inequities and then build mutually accountable systems for accomplishing this. And number three, balancing careful planning and flexibility. We won't reach our end goal, lifelong health of all people, without careful consideration of the partnerships we'll need to build to get there. This is not a healthcare conversation. Sorry guys, this is not a public health conversation. This has to be a community dialogue, and we will need to broker non-traditional relationships and partnerships to truly achieve health for all in Oregon. I guess what I want to leave you with today is this last thought. There's an interesting opportunity which presents itself when we think about the intersection between the two concepts we're talking about here today: public health modernization and health equity through authentic community partnership. In many ways, the fact we have so much work to do to build an effective and equitable public health foundation across our state presents an opportunity, given the changing demography of our population and the sustained and equitable health outcomes for our communities of color and in rural Oregon. What if we intentionally build this infrastructure in such a manner that we place equity at the center of the equation? So that while we're building a new solid foundation for public health, we're also building a new solid foundation for equity. I believe we can do this, and we must do this. In a state that prides itself on planning, in a place that has invested so much in sustaining this incredible environment we live in, why can't we invest that same energy, planning, and resource in our communities of color and our rural communities? Why don't we ensure that every Oregonian lives in a place that can nurture lifelong health, a state where place matters? We can no longer afford not to do this. So I hope you have a great day, and thank you for giving me the time to talk to you a little bit.